Wilson disease is a key metabolic disorder that affects the liver, primarily in the liver, but then affects in the other parts of the body also, like eye. It can affect the kidney, it can affect the brain, but primarily it affects the liver. It's an genetically inherited metabolic disorder. It is inherited through autosomal recessive mode, and the main problem here is this impaired copper excretion because copper accumulate in the body. Now, why exactly this copper accumulation occurs? To understand that, we need to understand that it's primarily occurs due to mutation in a gene which is known as ATP7B gene, which is located on chromosome number 13. It's also called Wilson gene. Now, ATP7B gene encodes for a protein, particularly an enzyme, a copper transporting enzyme of the same name, which is ATP7B. Now, normally ATP7B does two things. It helps in copper transport and excretion. That means ATP7B transports the excess copper from the liver cells into bile for excretion, and this way it prevents copper from accumulating to toxic levels in the body. And second, it also does an important work. It packages or incorporates copper into apoceruloplasmin to make ceruloplasmin, which is a copper binding protein. And this ceruloplasmin is important for transporting copper in the blood and is involved in the iron metabolism. So in this way, ATP7B protein is actually helping by protecting us from the copper toxicity, by facilitating the excretion of the excess copper. It helps us from toxic effects of copper buildup. Now imagine a scenario where this person has developed Wilson disease. So what would happen? This person would, ATP7B gene is mutated. So obviously that would produce a defective ATP7B protein. So this ATP7B protein, then it would not do its normal function. So it would not help in copper transport and excretion through the bile. Plus copper incorporation into apoceruloplasmin would also not be done. So the copper would neither be excreted through bile, nor copper could be circulated through ceruloplasmin into the serum. So what is going to happen, that this defective ATP7B protein would be causing decreased serum ceruloplasmin because the copper cannot be packaged into apoceruloplasmin. This is not done. So it would result in decreased serum ceruloplasmin, which is a characteristic feature of this disease. So obviously there is no way the body can remove the excess amount of copper from the liver. So progressively more and more amount of copper would be accumulating in the liver, and neither the copper can be excreted through the bile. So what would happen, progressively more and more amount of copper, as they're accumulating inside the liver cells would be damaged. The liver would show various kind of diseases or pathology like hepatitis, liver failure. It could also lead to cirrhosis due to this toxic effect of the copper buildup. At one point of time, what would happen, that this amount of copper would be spilled into the rest of the body, because this copper, as the liver cells are progressively dying, the copper would ultimately spill over into the blood, and this copper is unbound because there is no ceruloplasmin to bound this copper. Normally what happens, the ceruloplasmin binds copper, and in this way it helps that free copper is not moving in the body. One thing you must have noted, that free metallic ions are not allowed to move around the body because they can cause Fenton reaction, they can cause metabolic reaction, free radical mediated damage to the body, because these free metallic ions are like naughty childs. So they are not allowed normally to move around. There will be always a carrier protein for them. Just like for iron there is a transferrin. Similarly for copper is ceruloplasmin. So as this ceruloplasmin bound copper is, now this copper which is there in the serum, which is free copper, is not ceruloplasmin bound. So it would accumulate various sites. First it has caused damage to the liver, I already explained. Then it would go to the cornea in the eye, and in the descendants membrane they would cause deposition and causes a ring which is known as Kaiser-Fleischer ring, KF rings. Now, one thing you need to keep in mind that KF rings are not specific for Wilson disease only. It can be seen in other diseases also, which is cholestatic. And the copper could also be accumulating in the CNS, central nervous system. It could cause features like dystonia, Parkinsonism, tremors, and also not only the neurological symptoms, it can also cause psychiatric symptoms. Particularly if in a young patient, if you are getting liver features of liver disease plus neuropsychiatric symptoms, you should always think about Wilson disease. And in kidney, it can also causes a syndrome which is known as Fanconi syndrome. Fanconi syndrome is different from Fanconi's anemia, which is a inherited bone marrow failure. Don't confuse Fanconi's anemia from Fanconi syndrome. Fanconi syndrome is a problem of renal tubules. It's a proximal renal tubular problem. So this Wilson disease is one of the causes of the Fanconi syndrome. I discussed about this earlier also, the difference between Fanconi syndrome and Fanconi's anemia. So it can also cause hemolytic anemia other than this, non-immune hemolytic anemia. So it's a multisystemic disorder. It can cause deposit in the eye cornea, in the basal ganglia, in the central nervous system. It can cause damage to the cerebellum also. It can cause renal problem. It can cause hemolytic anemia, non-autoimmune hemolytic anemia, Coombs negative. So all this manifestation could be seen. And diagnosis, as I mentioned, it's initially you need to have a suspicion for this. If a young guy is presenting with liver disorder, if you're getting less than 35, somebody is presenting with cirrhosis, you should always suspect Wilson disease. And Wilson disease has not a specific liver feature. It can present with acute hepatitis, chronic hepatitis, liver failure, liver cirrhosis. Anything is possible. In the lab diagnostic, which is important, is plus also there will be other features as I mentioned, the neuropsychiatric manifestation and other features. With this kind of background, if you are getting lab diagnostic, the important point is there will decrease serum ceruloplasmin. Why I already mentioned you that ATP7B protein basically packages apoceruloplasmin plus copper to make ceruloplasmin. So apoceruloplasmin plus copper makes ceruloplasmin. Now what is happening here, that as ATP7B helps in this packaging, ATP7B. Now as ATP7B is not there, it's defective, so this packaging would not be possible, so ceruloplasmin level would be low in this condition. And as there is free excess copper in the blood, that could result in increased 24-hour copper urinary excretion. If you get these two findings, decreased serum ceruloplasmin plus increased 24-hour serum copper urinary excretion in the clinical backdrop of this presenting features, as I mentioned, you should always think of Wilson disease. In some inconclusive cases, liver biopsy can be done or genetic testing for ATP7B mutation is done. But mostly clinical features and lab diagnostic serum ceruloplasmin and 24-hour copper urinary excretion is diagnostic for this. So in essence, it's a metabolic disorder which primarily affects liver initially and then can affect other body parts also. And it occurs due to a mutation of a Wilson gene, ATP7B gene, which plays an important role in two ways. It helps in excretion of excess copper from the liver via bile, and also it helps to transport and move the excess copper into the serum actually through the help of apoceruloplasmin, because ATP7B incorporates or package copper into apoceruloplasmin to make ceruloplasmin. Now when ATP7B is defective, both these steps would not be possible. There will be progressive toxic buildup of the copper in the body, and it would gradually spill over first in the liver, then it will spill over to the rest of the body, causing progressive accumulation and damage. So this is in essence is Wilson disease. Thank you so much.